Well, welcome everybody for what is undoubtedly our most popular webinar so far. This is our fourth webinar, and I'm absolutely delighted to welcome Dr Dima El-Sharkawi to us today. She is a WM specialist in London, and she volunteered to do this particular webinar. Crazy lady, because it's the hot potato of the moment, as we all know, very serious thing about COVID. Vaccinations, antibodies, etc., etc., and we have had so many questions. So I just wanted to know that all of your questions have gone to Dima over the last couple of weeks, maybe apart from a couple of late ones this morning. She's seen all of those questions, so I'm hoping very much that she will cover, hopefully, most of your queries and your problems and your questions during her talk. But if I see any that maybe she's overlooked or missed, I will jump in at the end and ask her those. So once again, welcome everybody. And Dima, thank you so much for joining us today. It's a pleasure to have you with us, and over to you.
Thank you, Bob. So let's now share my screen. Now, if I share it like this, has this come up as, let me see, slide?
Yeah, that's fine. Yeah.
And that's come up as a slideshow now for you all.
Yes, it has. Yeah. Yeah.
Excellent. So for those of you who don't know me, my name is Dr Dima El-Sharkawi. I'm a haematologist at the Royal Marsden Hospital. I've been working there now for just over 3 years and specialize in treatment of lymphoma and the mature lymphoid malignancies, and including WM. So I've been involved with WMUK as a trustee and also as part of committee for the registry for a few years now. I just want to say that it's a real privilege I know this is a club that none of you really want to be part of, but it's a real privilege to work with you all, to see you in the hospitals. It's all very inspiring, as are the colleagues that I work with in WMUK, and Bob as well, setting up these webinars. So just want to thank you all. So for the next 40 minutes or so, I'm going to go through what is known about the impact really of WM on developing COVID-19 or complications with COVID-19, and obviously the hot topic of vaccinations. So I'm going to start by telling you what the objectives of this webinar are not. So what I'm not going to be able to do today in the next hour or so. I'm not going to be able to give you all the answers. That's partly because we may never know the answers to many of the questions that you have, and partly all the studies, particularly with the vaccinations, are starting to be published now onwards. So some of the slides where I'm referencing publications, they're publications that have only just come out last week. And you'll know from your own experience that, say, in the UK, a lot of the second vaccines have only been given in the last few weeks, and so results from the impact of those vaccinations won't come out for another few weeks in the literature. I'm not going to be able to tell you whether it's safe for you to go on holiday to Spain or anywhere else in the world, or to meet or hug your grandchildren, because I guess you have to work out what your risk is for your personal situation and whether you're happy to accept that risk. And the first couple of slides, I will be discussing a bit more about risk in general. So it's going to be a bit of a statistics lecture, but I think it is important to kind of get that idea of risk, because I'm not going to be able to take away all the risk. We're all probably aware of people who don't have any risk factors for COVID who unfortunately succumb to the disease. And it is just about that even in the young fit patients, or young fit people, I should say, there is some risk there, but it's working out why your risk might be higher and what risk you're willing to accept. So what is this webinar going to do? So hopefully I'm going to update you on the latest evidence that we've got, provide you with some of the tools so that you'll be able to start analyzing the data as it comes out in the media, as it comes out in the literature, so that you can start thinking about some of the things that we think about as clinicians in terms of processing this risk, and help you decide what is right for you. So as I said, Sorry, I was just going to hide myself from this. Okay. Can you hear me?
Yeah, we're still got you.
Okay. So first of all, what is risk? So risk is the chance that something bad is going to happen. And we all deal with risk in our everyday lives. So for example, there's the actual risk of something bad's going to happen, and there's what your perceived risk is. And what someone's perceived risk is might be very different. So for example, we all know people, or maybe those people ourselves, who are very scared of flying because you might be scared about something bad's going to happen when you're on the plane. So that's your perceived risk, although the actual risk of something bad happening whilst flying on a plane is actually very low, and much lower than a traffic accident when you're driving in your car or being driven, except we all drive every day and we all accept that risk. So we all deal with risk in our own lives. And when you were first diagnosed with WM, a lot of the questions that you may have asked was about the risks of responding to a certain treatment compared to not responding, for example. So we all deal with risk, and COVID-19 is no different to any of those other things. So when we're looking at the risk of COVID-19, I think is important to think about is, what are we all scared about? I mean, I wouldn't mind getting COVID-19. I knew I wasn't going to die from it or get long-term symptoms. If I knew that I was going to get it, but it was going to be a short, mild illness and I would fully recover, I wouldn't be so worried about it. But it is the thing that concerns everyone, quite understandably, is that risk of death from COVID-19, and potentially also that risk of so-called long COVID, where people are getting long-term side effects related to it. So I think this is a very important slide when we're looking at analysing the data in terms of the risk, but also in terms of vaccinations. And I'll be referring to this pathway or algorithm quite a lot during this talk. So let me take you through it here. So first of all, in terms of what we're scared about, which is either dying from COVID or those long-term sequelae from developing COVID. So to get to this point, which we don't want to get to, well, first of all, you have to be obviously exposed to the virus. Then once you're exposed to it, you actually develop COVID-19. And by this, I'm taking it to mean that if someone were to swab you, you were to get a positive result that we could detect the virus in your body. So of those, a proportion of people will be asymptomatic and will never know that they developed COVID-19. They may not have been swabbed, for example, and may not develop any symptoms. And some people, a proportion of people, however, will become symptomatic. And that's a big spectrum of things. So, for example, some people can have very mild symptoms related to COVID-19. I hear about people just losing their sense of taste or their sense of smell, but otherwise feeling completely well, through to a slightly more significant flu-like illness, through quite distressing respiratory symptoms that might mean that they need hospital admission or even intensive care support. And of those, a proportion of people will unfortunately succumb to COVID-19 or never completely recover from the symptoms, or at least up till now. So that's kind of the algorithm. And at each point, there is a risk if you get exposed of developing COVID. And if you develop COVID, there is a risk of becoming symptomatic. So each one is a different risk, if you like. So when we're looking at the overall risk of death from COVID-19, you need to look at all those different aspects. And the reason that it's so important, and I think it's quite nice to see it laid out like that, is actually when we look at publications to see what is the overall risk of death from COVID, different publications interpret it in a different way. And you'd think that this would be a fairly obvious thing to work out, because death, I mean, there's no two ways about it. Either you're dead or you're not. But there are different ways about thinking about that chances and that risk. And so chance and risk is essentially, it's an equation, if you like, or a percentage. So some papers will look at the number of people who die because of COVID over the total population in the country. But other papers will look at the overall risk as the number of people who die, not even necessarily because of COVID, but with a positive COVID result within the last 30 days. So they may have died because of something else, but happen to have a positive swab within 30 days over the number of people testing positive. So this equation, or this assessment of risk, is sometimes called the case fatality rate. So the number of people testing positive is your denominator, the bottom bit of the risk, if you like, and the top bit are the people who die from it. But you can automatically see, or die with having COVID positive results. So you can automatically see that there might be some things that can introduce inaccuracies, if you like, in assessment of risk with looking at case fatality rate. So, for example, at the beginning, when our numbers of COVID cases in March last year were starting to go up, you'll recall that actually the number of people we were testing was very much stricter than we are now because of the availability of testing. And so it was only those people who had symptoms severe enough to warrant admission into hospital that were actually being tested, who knew for definite that they had COVID. So at the beginning, this number probably underestimated the number of people who actually had COVID-19 and probably overestimated the risk. So this is from the UK case fatality rate. So this is looking at this equation. And as I said, that actually there was probably because of the numbers going up and it was the beginning of the pandemic, but also we weren't testing everybody. Our denominator was probably underestimating how many people had COVID-19 and therefore overestimating the case fatality rate at just over 14% here. Whereas if you come across here, so this is looking at date as we're going through the pandemic, right through to just the weekend from Saturday, you'll see that as the numbers of people obviously dying from COVID has gone down, but also our ability to test people and our availability of testing has gone up, that the case fatality rate for the whole population has gone down and has settled around about the 3% mark. So 3% of people who are testing positive for COVID are going on to die within 30 days of that positive test. And so that's up-to-date figures there. But obviously that's looking at the full population. So that's looking at people right from when they're born to their 70s or 80s. But on top of that, though, we know that there are certain risk factors for developing those severe complications from COVID-19, and some risk factors we may not know about. But if we go through some of the known risk factors, obviously the first thing is the rate of disease. So if there's a lot of people in the population that you're living in that have COVID, then your chances or your risk of being exposed is going to be much greater than if you're living somewhere where there's very few people who've got COVID, or perhaps you're in a community where where your houses are very spaced apart, so you're not living in big cities, for example. Your chance of being exposed is much lower. Human behavior and potentially household contacts can also affect your risk of exposure. So, for example, a lot of you will have been shielding over the past year, and that will also have an impact on your risk of being exposed to the virus in the first place. We know that there's certain things that we can't change about ourselves that will also have been associated or are a risk factor for developing severe complications. So we know that the older you are, the more likely you are to develop the severe complications from COVID. Men are more likely than women to develop severe complications, and there are also ethnic differences as well. And obviously, then also there are medical problems that we know that are associated with an increased risk of developing severe complications. Now, we know about diabetes, heart problems, blood cancers, but what we don't really know, and how we haven't really been able to tease apart very well, is how much of it is because of the disease itself, how much of it is because of the impact, say, for example, in the case of blood cancers, of the impact of that disease on the immune system, and how much is because of the treatment that we're giving for the disease that patients have. The other thing is that a lot that have shown, for example, that blood cancers, patients with blood cancers, I should say, have an increased risk of severe complications with COVID, that they've lumped all blood cancers together. So can you really compare, for example, a 20-year-old who has Hodgkin's lymphoma with a 50-year-old who has Waldenstrom's or an acute leukemia, and everyone's lumped into the same risk factor, which can make analyzing some of these things a bit more complex. The other things that make it complex is that these can all have an impact on your human behavior, for example. So, for example, if you're of an age where you're working, then you may not be able to, and you have your own business. I know many of our patients, as much as we've told them that they should shield, they want to keep their business going. So they've been continuing to go out and work because that's what they needed to do for their family. Similarly, many of our patients, and I think this was more of an issue right at the beginning of the pandemic in the UK, many of our patients were very good at shielding, but still needing to come into hospital if they had medical complications related to their disease. And I suspect before we had all the processes in place to reduce the risk of being exposed to COVID in the hospital, certainly I suspect that a lot of patients may have picked up COVID from going to their clinic appointment or from having to be admitted into hospital because of their medical problems. So you'll see that things then become more complex. That is it the actual disease itself that's leading to the increased risk of the complication, or is it the disease that's just increasing your risk of exposure? So when we're looking at risk factors, what I'm basically saying is how much more likely is it going to happen in a person who has the risk factor compared to someone who doesn't have the risk factor. So in this particular example, we're looking obviously at patients with WM. How much more likely is someone with WM going to have severe complications from COVID, for example, need intensive care support or die from COVID-19 compared to someone who doesn't have WM? And we can postulate why people with WM may have an increased risk of severe complications. So we know that WM affects your antibodies, not only the level of normal antibody production, but the function of the antibodies as well. That because this is a tumor or a disease that you may have for many years, that it can have an impact on the function of T cells, so not just the B cells that we know that Waldenstrom's impacts on. And also, as I said before, that the treatment for WM may also in itself be a risk factor for complications. But not only are there these direct risk factors, there's also what we call confounding factors. So things that we know patients with WM are more likely to have, not directly due to the WM, but that may also have a risk for the event. So for example, we know, and it's sorry to be ageist, but the median age of patients with WM is 70. So we automatically know that the majority of patients with WM are also going to have age as a risk factor for severe complications. As I mentioned to you before, that because of your WM, you're more likely to have to go to hospital to be seen by your haematologist. And is that going to increase your likelihood of being exposed to the virus? And also, as we all get older, we get more and more health problems as well. And how much of an impact do these have on your risk for severe COVID-19? So all in all, the reason I'm telling you this is, for example, that a patient who is 80 with WM may not have the same risk factors for developing severe complications with COVID-19 compared to 40 or 30-year-old with WM, who both have WM, but there are other risk factors that may also impact on that risk. So like I said, there've been a lot of publications that have shown that possibly patients with blood cancers in general have an increased risk of death or severe complications from COVID-19. But like I kind of alluded to before, I think a lot of it has been from skewed data. So we don't know how many of you, for example, had COVID-19 before we were even testing everyone so widely. And so there may have been many of my patients who do believe that they had COVID-19 who recovered, who didn't have any problems at all. I think one of the strongest papers to come out that did show evidence of an increased risk with blood cancers is this paper that was published just about a year ago now in Nature. And it was written by Ben Goldacre's group. Some of you may know from the media. He writes a lot about public health related issues in the media. And so the reason I think this was such a strong paper, and I'll bring you through some of the key results shortly, is that their denominator wasn't looking at the number of people tested, it was looking at the total population. So they've got this computer platform, if you like, called Open Safely, where they have access to 11 million GP records from the English population. So the chances are they probably got access, all anonymized, to our GP records, for example, or a lot of our GP records. And so because they had such a large denominator of 11 million people, they could look at each individual risk factor to see how much each risk factor added to all the other risk factors combined to work out the chances or the risk factors or the increased chance that each factor gives you of dying because of COVID-19. So this wasn't just people who had tested positive with a swab for COVID-19 and who died within 30 days. This were people who had COVID-19 on their death certificate, and they could compare what kind of characteristics these patients had, how many of them were male, how many of them were in their 80s, for example, how many of them had blood cancers, comparing it to the total population. And they came up with this hazard ratio, and I've highlighted some of the key ones, or I've expanded some of the key ones here. So let me take you through this. So this is a hazard ratio. And they will have a reference population. So for example, when it comes to age, their reference population is 50 to 59. So that they will set that as their hazard ratio of 1. Any age group that falls less than has a lower hazard ratio than 1 means that they are at a less risk compared to the 50-59-year-olds of dying from COVID-19 in this case. Anyone who has a hazard ratio higher than 1 has an increased risk compared to their reference population of dying from COVID-19. So if you have a hazard ratio of 2, you're 2 times more likely to die than someone in their 50s. So you'll see automatically, and as I said, I've expanded this out here for you to see it more closely, that actually being in your 70s or 80s had quite a marked increase in hazard ratio of dying from COVID-19. So that was looking at age. Like I mentioned, having being male as opposed to female gave you a slightly higher chance of dying from COVID-19. And the one that I'm sure most of you are most keen on assessing is the risk of hematological malignancies. Now, they lumped every blood cancer together. So again, what this means for a patient with WM, can't really tease that apart from this study, but they split patients with blood cancers into their reference population was not having a blood cancer, and then they split everyone who had a blood cancer into when they were diagnosed. And what they found was that those who were diagnosed within a year had the highest risk. So if you come here, it was just about 3 times risk over someone who hasn't had a blood cancer. And those then that had been diagnosed for more years ago, so within 1 to 4.9 years ago, had a slightly higher risk. And those that have been diagnosed many, many years ago had the lowest risk of that group. But all in all, those with blood cancer probably had a 2 times hazard ratio over patients that had never had a blood cancer. But these are just risk factors. They're not absolute. And obviously, if the risk is very low, then 2 times a low risk is still going to be a low risk. But the other thing to say, as I said, is that you can't take one thing in isolation, that it's everything. It's the age, the sex, the ethnicity, the other health problems as well. So I hope I haven't scared you too much about that risk and talking about death from COVID-19. Let's move on to, well, you've told me all these bad things. How are we going to prevent these complications? Well, one of the first ways that we tried to prevent it was stopping people being exposed to the virus in the first place. So regardless of how common the disease was in the general population, if you're formally and strictly shielding, then you're not going to get exposed to it. This is slightly more debatable about how much added impact this has, but probably does have some impact, that everyone having to wear masks prevents the virus being transmitted from one person to another, as does hand hygiene. And so even if you're potentially exposed to the virus, having that mask, making sure that you're not touching surfaces that have the virus and then touching your face, for example, is going to make you less likely to develop COVID-19. I'm not really going to touch on treatment, but obviously there have been many trials to see whether there's treatments so that once you have developed symptomatic COVID-19, how can we prevent severe complications from happening? And I'm not going to really touch on this only because most of the trials have been very small, and the bigger randomized studies haven't really shown that anything has been of benefit, apart from actually a UK study, the recovery study that many of you are probably aware of, which did show that patients who were already at the severe spectrum requiring support, lung support or breathing support, if you like, did benefit from steroids, which reduced that risk of dying from COVID-19. And obviously the other big thing, which I'll come on to, is vaccination. So that even if you're exposed to the virus, can we get a vaccination that's going to stop you developing COVID-19? So moving on to vaccinations. What do we want vaccinations to do? Well, that's fairly obvious. We want them to stop you developing the symptoms. And how do vaccinations work? And how can we measure their efficacy? And this is quite important because this will come on to some of the papers that have been published that have shown the efficacy of the vaccinations and some of the things to look out for there. So how do vaccines work? So vaccines basically work by training your immune system. So in your immune system, you've got B cells that produce your antibodies and T cells. And these are the targeted part of your immune system. They target specific diseases that they recognize and that they can basically kill. And what vaccinations do are basically priming that immune system to recognize the pathogen, the virus or the bacteria, for example, so that when you encounter it in real life, that your immune system already recognizes it as foreign and has already built up its army to target that particular virus or pathogen, so that it's ready to hit it and kill it before you develop the disease. So in this case, COVID-19. But so basically what it does is, and there's many ways that this can happen, is that the vaccine might introduce a small amount of that protein that belongs to the virus, or there's the mRNA, which viruses, which the Pfizer vaccine is one of those, where it allows your body's own cells to produce proteins that are similar to the viral proteins. And then that allows the immune system to be able to recognize it as foreign and then build some immune memory so that if you encounter that virus in the future, your immune system will respond to it. And that's essentially what we want it to do. So where do vaccinations work? Now, on my previous slide, I had put vaccinations block patients or people from developing COVID-19 once they've been exposed to the virus, but it may actually be anywhere along this pathway here. So it may be that some people might still get a positive swab even if they've been vaccinated, but just don't become symptomatic. Or you may have symptomatic, but the vaccination may actually be enough just to prevent you developing severe complications. So it may not be that it stops people getting a positive swab, for example, but it may be sufficient if it prevents people from dying from COVID-19. So it prevents the severe complications. So it may work anywhere along that pathway. And the reason that that's important is, as I said, in some of the papers, some of the endpoints to look at the efficacy of vaccination are slightly different. So to come on to some of the data from the vaccines, and I've just focused on the two main ones that have been used in the UK over the past few months, so the Pfizer and the Astra-Zeneca vaccine. There are obviously other vaccinations, including some that have been licensed and approved for use in the UK now, but these are the two that were first used. So the Pfizer vaccine, this was the trial on which the approval from the MHRA, so that's the UK regulatory body, gave the approval for it to be used in the UK population. So in this trial, they had 40,000 people in the trial, which I think is pretty amazing how quickly all of this has happened, and to have a trial with an outcome for 40,000 people. And they randomized people between either receiving the vaccine or receiving a dummy injection. So this would have been, for example, a water injection, if you like. And so this was blinded, and that means that the people receiving the injection, so the people on the trial, didn't know whether they received the actual vaccination or a placebo. And the people giving the injection didn't know whether they were giving the vaccination or giving the placebo. And the idea to blind it is that hopefully then it's not going to have an impact on the results, because, for example, if you know that you had the placebo as opposed to the vaccination, your behavior may change. That might have an impact on the results. So, for example, you may be more likely to stay at home and hide and not be exposed to the virus if you knew you had the placebo, whereas if you had the vaccination, you may partake, in more risky behavior, and because you feel that you're protected from the vaccination. So that's why it's blinded. So the endpoint, so this is the data that they're saying is going to prove that this vaccine is beneficial and that we should be giving it, was the percentage of people with symptomatic COVID-19 at least 7 days after the second vaccine. So if we pick that apart a bit, they basically would just test people at least 7 days after the second vaccine, because before that, if people were getting symptoms, they were worried that it's just because the vaccination hadn't had enough time to work. So it may not be because the vaccine's not working, it's just we haven't given it enough time. So they were testing people who developed symptoms. So if we go back to here, they weren't testing to see whether people were not developing COVID-19 positive swabs at all. They were only testing to see, are we reducing the number of people who are getting symptoms from the disease? So kind of testing at this area, if you like. But importantly, the median age of all the people on this trial was 52 years, and 2/3 of the population were less than 55 years old, and they all didn't have medical problems. So automatically, when you're looking to see, well, how does this data, is it relevant to me? If the majority of you, I'm assuming, are going to be older than this median age, you're going to have WM, and so this might not be directly relevant to you because it's a different population. Can we say that the vaccination is as effective in you from this data? And I think the answer is no, because we weren't testing, or this trial, I should say, wasn't testing older age group patients with other clinical health problems. But it was efficacious in this group. So let me take you through this, this graph here. So this is the number of days after dose 1. So this is the day that they had dose 1. So 3 weeks later, they would have had the second dose. So that's at day 21. And so they would have recorded the difference in the efficacy 7 days after that second dose. So from day 28 onwards, they were comparing the people who had symptomatic COVID-19, who had the placebo, which is this blue here, compared to those who had the vaccination. And this is something called cumulative incidence. So each time someone tests positive, then this bar will go up. So the more people who get positive results, the more this bar goes up. So out of the, but you'll see that even those that had the placebo, the incidence of getting symptomatic COVID-19 is still very low. I mean, obviously it looks this, you look at this graph and you see the separation of these curves is very marked, but actually percentage of the total population, even in those who didn't receive any active vaccination, was still very low at 2.4%, but obviously much higher than those who received the vaccination. But this is in a population where, if you'll remember the paper that I showed from Nature, actually the rate of developing symptomatic COVID-19 is very low anyway. But the vaccine in this population did show 95% efficacy. And when they looked at what we call a secondary endpoint, so it wasn't the main endpoint of their study, but they also looked at it as well, was the rates of people getting severe COVID-19. So these were people who weren't only symptomatic, but needed to go into hospital with COVID-19 and need perhaps lung support for their breathing or intensive care, or died from COVID-19. What they found, and this again sounds very impressive, was an 89% reduction in risk of severe COVID-19. But this 89% reduction is in very small numbers. So how accurate this risk reduction is difficult to tell, because obviously changes in small numbers one way or the other will make big differences in the percentage. And so the number of people getting severe COVID-19, as you would expect in such a young patient group, was actually very low. So even in those who had the placebo, there were only 9 people of the 20,000 who developed severe COVID-19, but only 1 in the vaccinated group. So that led to the 89% risk reduction. So that's from the trial, but that then leads to the vaccination being licensed. And the main thing often with this is to show that it's efficacious, but also show that it's safe. And then once that's happened, and this is often the way with trials, then once it's used in the population, we get what we call real world evidence, which then usually reflects a population which is as the title suggests, much more realistic. So this is actual patients or actual people rather than people going onto a trial. So much more reflective. And a lot of the early real world evidence has been published from Israel because they had a very good and quick vaccination program for the whole population. Now, let me take you through these graphs. So these are 4 panels of their whole population data, split according to the age, their age categories. So A is for the people that were over 65, B between 5 and 64, then these are the youngsters here in C and D that are 25 to 44 and 16 to 24 here. As we go along this way on each one of these panels are the dates ranging from December last year through to March of this year. The red line reflects the number of cases of people who have got positive COVID-19 swabs. So it's nothing to do with dying from it, it's just positive COVID-19 swabs. And in Israel, they had a peak around the January time where the numbers were high, and then it has started to come down. And they've put on the background, if you like, when people were being vaccinated. So the light blue is their first vaccine, and the dark blue is the second vaccination. So, and this is the percentage of people in that patient group, or in that age group, I should say, who've been vaccinated. So you can see that in this older age group, over 65, that they managed to vaccinate people, a large proportion of the population, very, very quickly. So within, what was it, about a month, they had managed to vaccinate with the first vaccine over 80% of the population, which is pretty impressive, and a similar kind of steep curve up for that second vaccination. And you'll see that as more and more people were being vaccinated, that actually the rate of the COVID-19 was going down. However, again, to add to the complexity of understanding how much of it is vaccination, is that there were other measures that were put in place that may have had an impact on the incidence, which is, I don't know how well you can see this on your computer screens, but in December, they had a lockdown. In later on, I think beginning of January, they had additional restrictions. So that also may have had an impact on the incidence of the COVID-19 going down. And once there's less in the population, then you're less likely to catch it. So even if you hadn't been individually vaccinated, your chances of getting it become much lower. But certainly a combination of the lockdown restrictions and the vaccinations, although as I say, difficult to know which one had more of an impact, had an impact on reducing that incidence of COVID right down. And this was reflected in all age groups, as you can see here. And in Israel, they had just licensed the Pfizer vaccine. So this is data from that Pfizer vaccine. So then going on to the Astra-Zeneca vaccine and the efficacy. So they had a similar endpoint that they were looking at efficacy from the first dose and looking at those who had symptomatic disease. And what they found was that those who had the vaccination had a 76% efficacy after the first dose of reduction in the chances of developing symptomatic disease. But again, similar to the Pfizer trial, 80% of the population that were studied in this AstraZeneca, the largest AstraZeneca phase 3 trial, were less than 55 years. But as well as looking at the rate of COVID-19 or symptomatic COVID-19, they did also look at antibody levels as well. And I'll come on to antibody levels shortly, but they did have different doses of the vaccine. So they were comparing the antibody response for the different doses of the vaccine. And you'll see the majority of people did achieve good antibody levels with the vaccine, regardless of the dose that they had. But even in this young population, you'll see that there were the odd few people who didn't develop high antibody levels. So I've told you these vaccinations are very good at reducing the risk of symptomatic COVID-19 in people who are young, but where is the efficacy for older people? So Public Health England are looking at this very closely and are updating their results, well, very frequently. And they are looking at people over 70 to see what are the chances or what are the odds of developing a positive COVID-19 result after the first dose of vaccination, either Pfizer, which is this one here, or Astra-Zeneca, compared to those who haven't been vaccinated. And you'll see that even in the older age group, that there is evidence of a decreased chance of developing a positive result. So this isn't just talking about symptomatic results. These are positive results from COVID-19. So this is looking days after the vaccination of onset of the positive result. So obviously your odds ratio is going to be, which is similar to your hazards ratio, which I described before, is going to be around 1 when you've just been vaccinated, because we think it probably takes at least 7 days to develop some protection. But then once you get past that, so day 10 onwards, that actually the chances, even in the older age group, of developing a positive result goes down. And that's the case for the Pfizer and the Astra-Zeneca vaccine. And so this is real world evidence that in the older age groups, these vaccines do work. So this is a publication, again, in preprint, so it hasn't been peer reviewed, but by the group on behalf of Public Health England, looking at patients or people who have got a positive swab, how likely are they to die if they've been vaccinated or unvaccinated? So if you remember that algorithm I showed you before, these are people who've been exposed, who have got a positive swab. Does the vaccination work kind of later on in the pathway and stop some of those people who get a positive result from dying from COVID-19? So, and it does look like the vaccination is active even in those who are still developing the positive test. So let me take you through this. So this, on the x-axis, are the days since the positive test. Those who are unvaccinated are in this blue line here. And so as you go more and more time, this is what we call a cumulative incidence. So each time someone dies from COVID-19, that's a step upwards on this graph. And you'll see that those who'd had that for the first 7 days, that the 3 bars, so this is the Pfizer, this is the AstraZeneca vaccine, all follow a similar path. And this is kind of what we'd expect. As I said, it probably takes about 7 days at least for the vaccination to prime your immune system. But we start to see a separation in these curves from the day 7 to 10 onwards, where having had the vaccination, people are protected from death, even with those that have got the positive swab. And they've estimated about an 80% protection. And this is a similar kind of graph here, but looking at those who've also had the second Pfizer vaccine, because this is all still very new data. Not enough people have had the second AstraZeneca vaccine, because you'll probably recall that the Pfizer vaccine was approved before the AstraZeneca one. So it's kind of further along on the pathway, if you like, and you'll see having that second vaccination leads to even more protection for people. So this is data that's kind of being continually assessed and examined over time. So I've talked about the trials, and some of the data I've presented has basically shown it's the measure of effectiveness of the vaccination, or how many people are getting either a positive swab or symptomatic swab or not dying from COVID-19. But that doesn't necessarily tell us how effective the vaccine is for any one individual. So for example, a vaccine may not work in someone who is, I'm not saying that this would be the case, but it may not work for someone in their 90s, for example, but they may still be protected because everyone around them's been vaccinated who's much younger, for example. And so the rate of COVID-19 goes down. So even though the vaccine's not protective for that individual, because the rate of COVID-19 is much lower, they're much less likely to develop COVID-19 and therefore much less likely to succumb to it. And so they still get benefiting from protectiveness, and that's what herd immunity is essentially, even if the vaccine wasn't effective for them. So this data is all very reassuring that it is providing effectiveness even in the older age group, but is it because that those people themselves are benefiting from the vaccine, or is it because of this herd immunity? And so partly because of that, partly because it's easier and quicker to measure, and partly because it's not dependent on exposure to the virus, many of the studies that are looking at the effectiveness of vaccination, and this is particularly when it comes to blood cancer, patients with blood cancers, are looking at surrogate markers. And by surrogate markers, I don't mean they're looking at the points that we're interested in from a clinical perspective, which is essentially, is someone going to die from COVID-19 or develop severe complications? But they're looking for things that might be more suggestive that people are going to be protected by the vaccination. And by that, I mean antibody testing and T-cell response. So I can't do any hematology talk without showing a slide similar to this one. This is like the tree of life for all hematologists, because it shows us how the bone marrow stem cells differentiate into the different blood cells that we all know and love. So in your bone marrow, where the factory where you produce all your blood cells, you've got these what we call pluripotent stem cells, which have the ability to become any of your blood cells. They can either go down a myeloid route, which eventually become your platelets, your red cells, or your granulocytes. And many of you will be monitoring, I know, when you're on treatment and things, your neutrophils, for example. Or they can come down your lymphoid route and become your lymphocytes, whether they be B lymphocytes, your T lymphocytes, and I'm sure a lot of you will be aware that Waldenstrom's basically affects your lymphoplasmacytic cells. So it's a tumor of your lymphoid cells that are differentiating into plasma cells. So these are the very cells that produce those antibodies that help you prime your immune system to fight infection. And your T lymphocytes are also important in fighting infection. So when we're vaccinating people, we're essentially trying to prime these cells to recognize the virus, to kill it if they ever get exposed to it. So as I said, vaccine response is dependent on your plasma cells, as they're the actual cells that make your antibodies. So if you've got non-functioning plasma cells because of the Waldenstrom's, for example, then you're less likely to develop that antibody response. That means that is your vaccination going to be less effective? And essentially what we want to do is that if we expose your immune system to a particular pathogen, or for example, the COVID-19 virus, then if we measured your antibody response, you will get an antibody specific to that virus, antibodies targeting that virus in specific, or a protein on that virus. We will see that you will get an antibody response, and then it will go down again. But you will get these what we call memory cells that will remember that protein that it was exposed to. And so that if you ever are exposed to it again, the idea being that you would get a much bigger antibody response, and it will be a steeper curve so that it'll be quicker to get to that peak antibody response, so that it'll help you kill the virus, if you like. And if you can do, if your antibody response and your immune response is quick enough that it stops the virus ever getting hold and causing problems, then that's protective, essentially. And we can test these antibodies in the blood, and we do it quite frequently for other viruses and other bacterial things. And sometimes we do it to assess response to vaccinations. And we know people with blood cancers, particularly those that affect that B lymphoid pathway, can often get a muted antibody response. And that's why we often do suggest that patients have repeat vaccinations to keep priming that immune system, because we know it's not quite as effective as if you didn't have, for example, Waldenstrom's. Can we test for T-cell response? So the short answer is both of these, when it comes to COVID-19, are research tools. We can test for an antibody response fairly easily in NHS labs because we do it in our routine practice. But actually, what it means and how does it translate to clinical impact for individuals, we don't really know. So in fact, a lot of the regulatory bodies advise not doing it as a routine clinical thing and only doing it as part of research, although because it's easy to test, a lot of us do offer that service. However, T-cell responses are much more complex to assess. They're not routinely done in NHS laboratories, so we don't have the abilities to test it even if we wanted to really in NHS laboratories, and so they are just the reserve of these research studies which are looking at vaccination response. So looking at some of these antibody and T-cell responses then, let me take you through this study which was published, I don't remember how recent, I think it was May, so this month in the Lancet. And this is looking at antibody response to the first Pfizer vaccination and comparing different age groups and also whether people had knowingly had COVID before. So as I showed you before, if this patient has already, or if a person's already had COVID-19, their immune system is already primed and will have those memory cells. So we'd expect a much better brisk response to the vaccination because they've already seen their immune system has already been exposed to those proteins before. So let me take you through some of the results from this paper. So this top one here is looking at antibody response, and this is a quantitative assessment. So it's measuring not just whether you've got antibodies or not a binary thing, but how many antibodies and what level of antibody response you get. And you'll see that those people that were under 50 to their first vaccination had on average a higher antibody response to those who were over 50. And we know this in many examples, not just with COVID, that a younger person's immune system is more primed and ready to react than older people, as all our immune systems kind of aren't as active, if you like, as we get older. And that's why people can get more significant infections as you get older. But these are just averages. So you will see that there are some people that are over 50 who get much better responses than people who are under 50. So when we're talking about these population data, they are just averages and risks. They're not absolutes. But you'll see that the much higher antibody response was, as we might expect, in those people who'd actually had COVID-19 before. And this is regardless of age, that they found that the antibody response to that first Pfizer vaccination was much better. And this is just split according to age of the patient. So you'll see that in the red dots were the people who'd previously been exposed to COVID, generally, but not absolutely. For example, there is a small red dot there, getting a much higher antibody response than those who had never been exposed to it. And again, it's just an average, but not an absolute, but you can kind of see that the black line went down with age. So, so that people that were younger tended to have a slightly higher antibody response than those who were older. This is another way of measuring the antibody levels, and this is looking specifically at in fewer patients, but from comparing day 0 to the antibody levels. And as you'd expect, Those patients in the black are people who've never been exposed to COVID-19 before, so they're not going to have the antibody. And those in the red had been exposed to COVID-19. Most of them had got detectable antibody levels, but not all of them. So this person here didn't have detectable antibodies. But then after 21 days, after 3 weeks following their first vaccination, that the rise in antibody levels was much steeper in those that had been exposed before, but that everyone essentially got that rise in antibody levels. And then this bottom panel here was then looking at that T cell immunity and the T cell specific response to the first vaccination. And these are the different proteins, if you like, that they're testing the T cell response to. And again, you'll see that there was a much better response in those who'd been exposed to the COVID-19 before. All in all, showing that hopefully then when they extend this study out, we'll also have that second vaccine and what impact that has had, because obviously these people will go on to have a second vaccine, and what we would hope is then that their response is much better, similar to those who've had the disease before. So what about COVID-19 vaccine responses specifically in WM? Now, there are a lot of studies, and if you go onto clinicaltrials.gov, you'll see many around the world that have been set up to look at vaccine-specific responses in certain disease groups, and myeloma and WM. There are a few that have been set up in that, I think, in the US, and there are some studies that are being set up in the UK. I think a large one that's being funded by blood cancer is the Prosecco study being run from Southampton, which is going to be looking at lots of patients with lymphoma, and they will include patients with WM in there, and there are other smaller studies happening in the UK as well, but none have specifically reported yet in WM. And like I said, it's not just a question of does someone have WM or not. We don't really know what the impact of the length of time since diagnosis, whether the current disease burden, treatment history, how much of those things have an impact on the vaccination response. So what have we got so far? So this was the first study that was the data was released, the SOAP study from King's, which was looking at vaccination response in 150 patients with cancer. And of those, about a third had a blood cancer. Of those, 38 had B lymphoid cancers and 1 had WM. And what they found, and this was just response to the first vaccination, so we don't know, it hasn't reported yet for the second vaccination, but those that they had healthy controls that they were comparing it to, and this was both antibody and T cell response. They found in their study that whilst over 90% of healthy controls mounted an antibody response, only 40% did with solid cancers. So this is to the first dose, and only 13% in those with blood cancers. But we don't really know which ones of those, and they're quite small numbers to be able to really learn too much at the moment about that. There's been a paper more recently published by some of my myeloma colleagues at the Marsden looking at vaccination response in myeloma, which I know isn't the same disease as WM, but it is a cancer of the plasma cell. So they have some of the similar issues in terms of lack of functional antibodies. And so my colleagues looked at 93 patients with myeloma and tested this specific antibody response to the first vaccination, but also total IgG. And what they found was actually the overall response was better than was reported in King's at about 70%. But this was just looking at antibody response, we didn't have the facilities to look at T cell response. But what they found in their cohort of, I guess, more homogeneous malignant patients, in that all the patients had the same diagnosis, was that not being in a good disease response was more like those patients that had a high burden of disease had a lower chance of response. being on treatment was associated with a lower chance of response. Having low antibody levels to begin with was associated with a lower chance of response, and having had more lines of therapy. There are a couple of studies in CLL, again, another B lymphoid malignancy, and I guess the CLL is often one that's commonly studied in these things, just because there's many, many more patients with CLL than there are with myeloma or Waldenstrom's. So there's one that was only published last week from the US, where they looked at 44 patients with CLL to look at their antibody response, and they found that 50% of their patient cohort had a response, and it was more likely in those who were on watch and wait than on treatment. And there is going to be very soon, it just hasn't been released, some data from Prof. Moss from Birmingham looking again at a CLL cohort, but we don't have that data yet. So then just the final couple of slides, I'm going to touch on risks. So we know that there's the risks of vaccinations, and I'm sure a lot of you have experienced some of the milder risks, such as the temperatures, the headaches, the flu-like symptoms. Although there's anecdotal evidence, like when I talk to my friends and myself, I had worse side effects with the second dose than I did with the first dose, and people kind of think of logical reasons why, that your immune system's already primed, and so you're more likely to develop these adverse events or side effects, if you like. But actually from the trial data, it doesn't look like there was obviously increased side effects with the second dose. Some people with blood cancers, there have been reports of having a temporary flare with the vaccination. So we've had a couple of patients who perhaps have enlarged lymph nodes that have got a bit bigger following the vaccination, but then settled down again. And I think one of the questions was regarding stopping ibrutinib to have the vaccination, that either themselves were advised or someone they knew was advised to stop it. And I wasn't quite sure whether that was because of the bleeding risk with ibrutinib, and so they were stopping it, you know, before the injection and after the injection to reduce that bleeding risk, or whether it was because of perceived reduction in efficacy by being on ibrutinib. Because, like I said, some of these studies have suggested being on treatment is associated with a less chance of responding, but we don't have any evidence that temporarily stopping your treatment is going to lead to an improvement in the response. So unless it was for bleeding risk, I wouldn't be advising patients to stop ibrutinib to improve efficacy, because we don't have evidence that that will be the case. A very sensible question came in about this risk, this very rare risk of clots with the Astra-Zeneca vaccine that's been called VIT now. And that given that patients with WM are at increased risk of developing blood clots, should they be avoiding the Astra-Zeneca vaccine? But it's a different mechanism of developing the clot. So the way that patients with WM are at increased risk of clot is completely different to the way that this condition causes a clot. So we don't have any evidence that actually having a blood cancer increases your risk of this complication, so that we don't have any evidence that one injection at the moment is better in terms of efficacy or in terms of less side effects for patients with blood cancer. So the advice is, as it has been before, go with whichever one is offered to you, unless there are other reasons not to have that particular vaccine. So my final thoughts are, there are a lot of publications that are going to be coming out over the next few months. Like I said, some of the trials that I was talking to you about, they only were published in the last few days. And, you know, as more and more people have been vaccinated and as all the data is collected, I think we are going to get hundreds, if not thousands, of papers about the efficacy of vaccines. So, and I think it will come in different patient groups. It's always the way. It starts with blood cancers in general, and then as we get more and more data, people start kind of nailing into the different disease groups to get some more granularity, if you like, on the outcome. So there will be a lot of data coming out. And ultimately, even if the vaccination doesn't work for you, and testing for that, I hope I've relayed, isn't absolute. So even if you have a negative antibody test, for example, doesn't mean you're not protected from the vaccination. There may be other ways that we can't test for that means that you're protected. But also, if the rate of COVID is very, very low in the population, that your chances of getting it in the first place becomes much, much lower. And so herd immunity may be play a part anyway, so you will benefit from others being vaccinated around you. And the other final thing to say is that this is all short-term look at the response to vaccinations. Obviously, once we get this wave of publications on responses to vaccinations, then will come the data about long-term immunity. Are we going to need boosters? Are there going to be better ways to protect people who don't have a good response? And with that, I just want to say thank you for listening to me drone on for, I don't even know how long I've been droning on for, a long time. And that's it.
Okay, Dima. Wow, that was something else. I've got to say, you used the word death too many times for my life.
I'm sorry.
That's just a personal observation. Can I just throw a couple of quick, I think, first of all, you've covered most of the questions that I sent on to you. You've answered most of those in a different format. But a lot of the people are saying, I mean, one lady in particular, I think she paid to have an antibody test, and it turned out that she had very low, almost negligible antibodies. So for us WMers, is that something, although we're not going to get it done by our clinician, is it something we should consider, or is it not worth doing? I mean,
so like I said, there are a lot of centres, and ours included, where we can easily request it. So if there's any Marsden patient, we can test it. But I tell my patients that actually, whatever the result, I'm not going to change what I do for you. I'm not going to change what I advise to you, because we don't know what a negative or positive antibody result means, apart from we can pick up antibodies. Like I said, it is a surrogate marker, so it doesn't definitely mean that if you've got a negative antibody result that you're not protected at all from the vaccination. There may be other things that protect you that you're that we can't test for, essentially. And then on the flip side, if you've got a positive antibody result, you might be pleased and excited and say, wow, I'm protected. But we don't really know how long that positive antibody is going to last for, and whether having a positive antibody result or a negative antibody result is then going to lead to, what the more important thing is, reducing that risk of severe complications. So there's still a lot of unknowns. So I don't think it's a must. And as I said, a lot of regulatory bodies are suggesting not to test for it, because it's still a research tool rather than a clinical tool that we can change what we advise you to do. But having said that, there are lots of places testing for it, and our centre included.
Okay, thank you. And I think you really opened up your webinar with the whole thing about risk, and that is, at the end of the day, I think most of us in this situation, is about assessing our own risk. The lady who wrote to me this morning, her grandchildren are going back to America. She wants to know if she can hug them. Well, if she goes through that risk assessment that you've talked to us about, then she's got to make that decision for herself.
And everyone's willing to take different risks, aren't they? Because I mean, it's also, there's the actual risk, and there are things on the website. I think the University of Oxford have a risk calculator that it'll go through all the different risk factors and come up with a total risk, looking at all of those things. But ultimately, for example, some people might decide they want to go and bungee jump because the advantages to them and the exhilaration or whatever they get out of it outweighs the risks, whereas I'd say, why put yourself through that and that risk? And there is, I mean, I know that's a completely different example, but it is how much risk you're willing to take. And I can't answer that for patients when they ask me. So I kind of go through, obviously much quicker than I did today, but that risk assessment and help them make the right decision for them. Okay.
Well, Dima, thank you so much for taking on such a challenging subject. And like you say, you kept alluding to, it's still early days, isn't it? I know we're just over a year in now, but it's still early days for you guys with your research and results to come out of what's happening with our jabs. I'm looking at my screen, and I'm supposing most of us, except Kat, have had our 2 jabs. So we've got to, you know, take our own risk assessment and move on. But thank you so much for joining us today. Really do appreciate it. And thanks for your time. And just a heads up, guys, we've got Dr. Guy Pratt coming on next in about 4 weeks' time. He's going to talk about WN guidelines, etc. So get yourself registered for that. And some exciting news coming out today and tomorrow about some smaller support groups. We're setting up a Scottish clan of about 6, 7, 8 of us now. That's going to be coming up, and some interest in a West Midland gang. We're going to call it WM in WM. How about that? And then I can see Mary on there. Mary Giles is going to help me set up one in the southwest, and Lucy, I think, is on there somewhere in the southeast. So we're going to get these things going, and remember what I say on all my things, we don't want to leave anybody behind. So join in with our support groups, and let's all get to know each other and support each other as we go along. Thank you so much, Dima. Thank you, Kat, once again.